Hello everyone, welcome to this video. We will be discussing the dermatology recall questions asked in the just conducted INI CET November 2023. Even though with a new concept announced just 2 days prior to the exam, and even in the exam the time management was tough, especially in paper 1. I would say, at least for dermatology, they compensated by giving us fairly simple and straightforward questions. Most of the questions in derma were either direct repeats from the previous paper or they were similar topics which have been asked. So I hope all of you got the dermatology questions correct. We've discussed this through and through the regular videos in the classes and even the INICET masterclass that we just conducted. So I hope you all got all the questions correct, and now wishing you all the best for your upcoming result. So starting with the first question, now looking at this question, you know that this is a direct repeat from the May 2023 paper, and a similar questions with a little different options was asked even in November 22. So this question has been asked for the third time, classification of alopecias into scarring and non-scarring. Now this question here is asking us which of the following is not a non-scarring alopecia. We have alopecia areata, frontal fibrosing alopecia, androgenic alopecia, and telogen effluvium. Now here, alopecia areata, you've heard many a times, it is a patchy non-scarring alopecia. So yes, this is a non-scarring alopecia. Telogen effluvium, diffuse non-scarring. Androgenic alopecia, pattern non-scarring. So all of these are words that you've read here or there in your preparation on non-scarring alopecias. Other scarring alopecias also you must have read, but this particular disease, frontal fibrosing alopecia, you may or may not be knowing. Now here, if you know, good. If you don't know, just look at this word of fibrosing alopecia here. So when you read this word fibrosing in itself means fibrosis. So there is a scarring here. So even if before this exam you didn't know this word, but in the exam, just in dermatology, many a times the names of the diseases in itself tell you what is happening here. So when it says frontal fibrosing alopecia, fibrosing word should tell you that this is a scarring type of alopecia, and thus it is the correct answer here because this is not a non-scarring alopecia. So the correct answer to question 1 is option B, that is frontal fibrosing alopecia. Now a quick revision of these alopecias. When we talk about this, we divide them into non-scarring and scarring. Non-scarring in itself tells you that there is no scarring here, thus the alopecia is temporary and there will be a regrowth on treatment. On the other hand, scarring alopecia tells us that there is scarring, there is damage to the hair roots, there is damage to the skin, and thus it is a permanent hair loss with no regrowth. Now, this is very important to prognosticate the patient, and also, as you see, very important for the exam. So for the non-scarring alopecias, I have a mnemonic which is called as treats. Now, if you just remember this list of non-scarring alopecias, you automatically can answer any such questions. So don't be bothered by looking at this long list of names. I would suggest just remember one list. And the easier one, the important one, is the list of non-scarring alopecias. The mnemonic here is treats. So look at this. T is for trichotillomania, R areata, E effluvium, A androgenic alopecia, then tinea capitis, and the S stands for secondary syphilis and SLE. So the important diseases here, remember as T R E A T S. That is treats. If you remember this, half, but I would say 90% of the job is done, because whenever you get such a question, just rule out what is treats. Now, scarring alopecia is also a very probable question in the INI CET exam that can be asked is, which of these is a lymphocytic and a neutrophilic alopecias? So I've put the list in such a way that you also remember as per the infiltrate, which is lymphocytic and which is neutrophilic. The lymphocytics can be remembered as BL and the neutrophilics as CD. Now, in the B, we have pseudopillard of Brock and frontal fibrosing alopecia, and L is the LPP and DLE. So, BL are the lymphocytic alopecias. Then CD includes dissecting cellulitis and folliculitis decalvans. So BLCD are the scarring or the cicatricial alopecias. Other than that, we have morphea, traction alopecia, chorion, burns, trauma, multiple other causes. But for your exam, these are the most important non-scarring and scarring alopecias. Remember, treats BLCD. That's enough. And as you can see here, I've put this question asked in 22, question asked both the times in the 23 paper. Now, coming to the second question, again, this question was much, quite often asked in the previous times AIMS exam, even though in the INI CET they've asked for the first time in the last 3 years. But if you go back and see at the previous AIMS questions, this was a very favorite one. And in fact, this classification of alopecia is also very favorite of the previous AIMS papers and PGI papers. So, they are now getting questions from the previous times back. Now, a patient on immunosuppressives develops white lesions on the tongue which cannot be rubbed off. What is the causative agent? So the question here is first of all telling us that the patient is immunosuppressed. He's on immunosuppressives. And then there are white lesions on the tongue which cannot be rubbed off. Now, whenever we have white lesions in the oral cavity, there are multiple causes. The causes can be Candida, causes can be EBV, and other than that, we can also have Leukoplakia as another cause of white patches in the oral cavity. Not so often, but there is another disease which is called as diphtheria. That is also there, but that is more when you have a patient as a child. Now, coming to the important causes where we have Candida, EBV and Leukoplakia, when the question tells us that the patient is on immunosuppressives, the important causes are Candida and EBV. And when the question tells us that there is history of smoking or tobacco chewing, then we have to include Leukoplakia as well in the differentials. Now, in immunosuppressed patients, I have told you we have to think of Candida and EBV. Now, Candida and EBV both have a white membrane. But the most important difference is that in Candida, the membrane can be rubbed off. So you take a piece of gauze and you try to scrape off the membrane, it will be rubbed off. On the other hand, in EBV, it cannot be rubbed off. So that is the most important way to differentiate between these two. Of course, the morphology and other factors come into play, but it is the rubbing off of the membrane which gives you the hint. Now, what does this question say? It says membrane cannot be rubbed off. So now you tell me what is the answer when the membrane cannot be rubbed off? The answer is C, that is EBV. Now, HSV is herpes simplex virus. This is going to cause herpes where we will have vesicles. So, not a question that this is going to be the answer here. HHV 8 causes Kaposi sarcoma in immunocompromised people, immunosuppressed people. Those will be red lesions. And in fact, this was a question asked in the Neet 2023, where a patient of HIV had reddish purple lesions in the oral cavity. What is the diagnosis? The diagnosis was Kaposi sarcoma. So here the lesions are going to be reddish purple. But when we talk about white, it is Candida and EBV which you have to see. Now, in this image here also, like this is a question which does not really require an image. The text in itself was sufficient for us to make a diagnosis. But if we look at the image, again you see a white corrugated plaque which has these feathery margins. Do you see these feathery margins? So this is a very typical lesion of oral hairy leukoplakia. Talking about it in a little detail, this is caused by the Epstein-Barr virus. seen generally in people who are immunocompromised, especially those who may be suffering from HIV/AIDS. And here the patient presents with a white plaque with a rough corrugated surface. It gives a stuck-on appearance. And if you look at the margins, these margins are classically feathery margins. So that's a very typical description, a corrugated plaque with feathery margins which cannot be rubbed off, and it does not require any treatment of its own. When you start the patient on antiretroviral therapy, generally resolves on its own. And a very important differential for this is Candida, which also looks like white membrane in the oral cavity, but this is actually a pseudomembrane. So this is also called as pseudomembranous candidiasis, and here the membrane can be rubbed off, and as you scrape it off, you have a red, raw, oozy erosion that is left behind. So this is the difference between candidiasis and oral hairy leukoplakia. Now, coming to the third question, a patient presented to the OPD with pain in the genital area. On examination, multiple painful coalescing vesicles with painful lymphadenopathy were present. What is the causative organism? Now, we have talked repeatedly in our discussions that STDs is a very important topic for all exams. So there ought to be one question at least in every paper, if not more. So here what they have given us is a patient who is suffering from painful lesions in the genital area. Now, what are the options? Herpes simplex, human papilloma virus, mollusky pox virus, and varicella zoster virus. Well, varicella zoster virus does cause painful vesicles, but they are not particularly in the genital area. They are dermatomal when it causes herpes zoster. So this is ruled out. Molluscum is going to cause pearly white papules, which are asymptomatic, not painful. Human papilloma virus causes genital warts, again not painful, not the answer. So what is the correct answer here? Very simple, straightforward question. Herpes simplex virus is the correct answer here, because this is the one that causes these painful lesions, which is called as genital herpes. And the question tells us that the patient has vesicles with painful lymphadenopathy, very classic feature of genital herpes, caused most commonly by herpes simplex virus 2. But also remember, for the purpose of multiple choice questions, that even HSV1 can cause it. Okay, so both HSV2 and 1 can cause genital herpes, but the most common cause is HSV2, and it is also the most common STI in the world. Now, this question was also asked in May 21, so it is a previous year repeat. Now, how does it present as? It presents as multiple grouped painful vesicles on a red base, and sometimes these vesicles can rupture to form erosions, and these erosions will coalesce to form polycyclic erosions. So the word polycyclic is also sometimes used for erosions in genital herpes. So patient has grouped painful vesicles along with bilateral painful inguinal lymph nodes. So this is the complete presentation with which the patient comes to you. When you do the bedside test Zank smear, stain the Giemsa stain, what you see is this beautiful finding of multinucleate giant cells. So this is a very classic finding of genital herpes, which is multinucleate giant cells. But on its own, herpetic infections are a cause of secondary acantholysis. So they are a cause of secondary acantholysis, and because of the secondary acantholysis, you see vesicles, and they also contain acantholytic cells, also called as Zank cells. So the complete finding on Zank smear would be multinucleate giant cells plus acantholytic cells. Look at this image here. Do you see any round cells with a large nucleus? Yes. These are all acantholytic cells. They are classically round in shape with a prominent nucleus and a perinuclear halo. In fact, this was the question which was asked in May 21. They gave an image of genital herpes and asked what would the smear show. That didn't have meninges as the option, that had it acantholytic cells in the option. So this was the correct answer in the May 21 paper. Okay, so this is actually a previous year topic, not a direct question. Drug of choice, acyclovir 400 mg TDS for 7 days in a primary infection. Now, one more thing you have to remember, in genital herpes, the virus will go and lie dormant in the sacral ganglion. And from here, whenever there is a trigger, it can come back. It can cause secondary episodes of genital herpes. So this is actually a chronic lifelong infection that the patient has. The virus is not going to go anywhere out of the body. It is going to stay dormant in the sacral ganglion. In fact, that is why there are such high chances of transmission, and that is why it is the most common STI that you see in the world. Now, about the other two options, I've put that image also. See, this is an image of genital molluscum. Here you get pearly white dome-shaped papules with a central umbilication. They, when present in the genital area, are most commonly caused by molluscum vox virus type 2, and they're common in people who may have AIDS, HIV, or other STIs, because one STI increases the risk of other STIs. And then we have genital warts. They are caused by human papilloma virus. Here you get skin colored to fleshy pink to slightly hyperpigmented papules with a rough verrucous surface and slightly pointy tips, which is why they are also called as condyloma acuminata. So this is just another name for genital warts. Condyloma acuminata, caused most commonly by HPV 6 and 11. The high risk HPV are 16 and 18. Okay, so they look very different from genital herpes. They are not vesicles, they are solid lesions. Now, coming to the question number 4. A 25-year-old young male presented with asymptomatic scaly patches present bilaterally on the trunk. Identify the pattern of the rash and the specific disease. So what are the points in the question? First of all, there is an asymptomatic scaly rash which is bilateral, and what is the pattern? Now, what do you see in the image? In the image, you see multiple patches which may have scaling, and if you look at the lesions, a little wishful thinking is sometimes required. In dermatology, the lesions here are present bilaterally in a line, and these are actually the lines of cleavage. And what you see here is the classic Christmas tree pattern. So this is the classic image of Christmas tree pattern. Now, where is Christmas tree pattern seen? It is seen in P. rosea. Now, the scaling may not be so much visible here, but if you have identified the pattern, you have identified the disease, you also know what is the type of scaling seen here. So, colored scale, Christmas tree, P. rosea. Absolutely correct. This is the classic image of Pityriasis Rosea. Lichen planus, no. First of all, lichen planus lesions are itchy. They are associated with itching. And secondly, they are more common on the flexures. And even if they're present on the trunk, they're not following the Christmas tree pattern. Christmas tree lichen planus, no. Warnoff ring is seen in psoriasis. And this is not seborrheic dermatitis, so this is also not the answer. So the correct answer here is option A, that is Pityriasis Rosea. Again, this question is a direct repeat from the May 23 paper. There also you had to choose between LP and P. rosea. Here also you have to choose between LP and P. rosea. Now, when you look at the word Pityriasis Rosea, look at this. Pityriasis means scaling, and rosea means red. So here what you have are red scaly patches. Typically, this is a hypersensitivity rash. It may follow any viral infection. Most common association that has been found is with HHV7. It can also be drug-induced. When it is drug-induced, then there are more chances of the lesions being itchy. Other than that, idiopathic or viral infections, mostly this is an asymptomatic rash. The first rash that comes on the body of the patient, this is called as the Herald patch or the mother's patch. And about 1 to 2 weeks later, we have multiple lesions on the trunk along the lines of cleavage. And this is the typical Christmas tree pattern that we see in Pityriasis Rosea. Very, very, very important question. And this pattern is the Christmas tree pattern which has been asked in the exam. When you look at all these lesions closely, you see that they are beautiful red annular plaques with central clearing. So they are annular, they are ring shaped, and the scaling here is arranged in a collar form. It is peripheral. So what you have here is a classic peripheral collarette of scaling. This scaling is attached on the outer side and it is free on the inner edge. So this is the typical scaling of Pityriasis Rosea. Classically, the lesions are asymptomatic in a Christmas tree pattern, and this is how they look. So this is the correct answer. Again, this is a repeat question. Lichen planus I've put here to show you how do Wickham's stria look. See, lichen planus are first of all purple polygonal papules. So they are not red scaly patches. They are purple polygonal papules. They are itchy. They are on the flexures more. And the Wickham stria that you see here are the lacy reticulate network that you see on the surface of these lesions, more visible in the mucosal patches. So Wickham stria is classic of LP, and this is how it looks like. Absolutely not what the exam gave us. Now coming to the fifth question, again vesiculobullous diseases is a very favorite of the INI CET exam, very favorite. Now here patient has presented to us with oral ulcers, flaccid blisters on the skin. Histopathology findings are shown below. What is the diagnosis? As I have repeatedly told you in all our discussions, whenever the question gives us bulle, the first thing that you have to notice whether it says the word flaccid bulle or tense bulle. So when it says flaccid, you have to think of pemphigus. And when it says tense, think of pemphigoid. Okay, so here what does the question tell us? Flaccid bulle. Now, when it says flaccid bulle, look at the mucosa. If the patient has presence of oral ulcers, there is presence of mucosal involvement, the answer is always Pemphigus vulgaris. And if there is no mucosal involvement, the answer is Pemphigus Vulgaris. So this is going to be your approach to all questions on vesiculobullous diseases. Again, here the text in itself is telling us what is the answer. Is it pemphigoid? No, it has tense bulle. IgA pemphigus is different. This is not how it presents. It has small pustular lesions. In Pemphigus vulgaris and Pemphigus Vulgaris, the presence of oral ulcers tells us that the patient is suffering from Pemphigus vulgaris. Again, I tell many of my students, don't be afraid of image-based questions. Many a time, the text in itself is sufficient to tell us the correct answer. So it's okay if you can't identify the findings in the image. In the oral hairy leukoplakia, in this question, the text in itself is telling us the answers. But let us look at what the image is showing us. See, in the image, first of all, see that this is an image of the skin where we can identify the epidermis and the dermis. So trace the basement membrane. This is the basement membrane. Where is the cleft? The cleft is above it. It is in the epidermis. So again, the image tells us that this is an intraepidermal disease. In about 2017 or so, this kind of an image alone was given and we were asked to identify the diagnosis. So, even this image in itself can tell you what the answer is. Now look at this image. You notice that the bulla, the cleft is in the epidermis. So this is an intraepidermal disease. It's an intraepidermal disease, means it is pemphigus. The cleft here is just above the basal layer. So this is suprabasal cleft. And if you look at the basement membrane, you see that these cells may be attached to the basement membrane, but they are separate from each other. So this is the row of tombstone appearance. The image is giving us suprabasal cleft with row of tombstone, which again is classic of Pemphigus vulgaris. Image itself also gives us the diagnosis of Pemphigus vulgaris. So very nice question here. The text and the image both give you the answer. Now, I've just put in a small discussion about how to differentiate between vulgaris and foliaceous. Vulgaris has involvement of both desmoglein 3 and 1. Foliaceous has desmoglein 1. 1 comes first. So foliaceous mein F comes first. So just remember F of 1 is in F. So Pemphigus foliaceous has DSG1 involvement. Now both of these will have flaccid bullae because they are intraepidermal, but since foliaceous does not have desmoglein 1 in the mucosa, so mucosa is not involved. Here you don't have any mucosal involvement. That is the main difference between vulgaris and foliaceous clinically. In vulgaris, patient will have mucosal involvement, so the question will say that the patient has oral ulcers. That will not be the case in foliaceous. When you look at the bullae, they are all flaccid, wrinkled bullae. Now, epidermis is not a very good roof for the bullae. As it tries to become big, it will rupture, it will become wrinkled, and that is how you will see them as flaccid bullae. With oral ulcer, vulgaris, no mucosal involvement, foliaceous. When you see the histopath, Pemphigus vulgaris, again, this is the epidermis and the dermis. Trace the basement membrane. This is stratum basal. So the cleft is just above it. You have a suprabasal cleft, and there are floating acantholytic cells which are derived from stratum spinosum. This question has also been asked. And the second finding that you see is the row of tombstone appearance. Again, classic of Pemphigus vulgaris, question asked in the previous exam. So this is also almost a repeat question. On the other hand, when we come to foliaceous, trace the basement membrane. So this is the epidermis, stratum corneum, stratum basal. Where is the cleft? Cleft is just below the stratum corneum. So this is a subcorneal cleft. Again, you see floating acantholytic cells in the cavity, which are derived from stratum granulosum. DIF is the same, fishnet IgG. So you cannot differentiate based on DIF. It is only the histopath which tells us the difference. Now, coming to the next question here, what type of image is shown here? So what do you see? You see again that there is a green colored fluorescence along the basement membrane zone. Now where do you see this green colored fluorescence? You see it in DIF. A lot of you may have read this as just a DIF finding. So here we have the full forms: direct immunofluorescence, indirect immunofluorescence, fishnet, row of tombstone. These are definitely not the answer. Now there may be different options in the exam. Please tell us the correct options in the comment section, because this is just recall based. Now, when you have read DIF, just extrapolate. Know the full form of DIF. It is D, I, and F. So this is direct immunofluorescence image which is given here, and that is the correct answer to this question. It is direct immunofluorescence. Some important DIFs in the exam: the fishnet IgG pattern in pemphigus, the linear IgG C3 at the basement membrane zone in bullous pemphigoid, and we have linear IgA at the basement membrane zone in linear IgA disease. So just remember, it is IgA in linear IgA disease and it is IgG in bullous pemphigoid. And then we have this granular IgA at the basement membrane zone. This is seen in dermatitis herpetiformis. So these are some important DIFs for your exam. So now coming to question number 7. A 13-year-old obese girl presented with velvety hyperpigmentation on the neck as shown in the image. What is the diagnosis? So what is the image showing us? Here we have pigmentation on the neck of this girl and it has a velvety appearance to it. Now, what is this? A typical setting of an obese patient having this high velvety hyperpigmentation on the neck. Amongst the options, Acanthosis Nigricans, insulin resistance, Hayran syndrome, Cushing syndrome. What is the answer? I hope you all know the answer. The answer here is Acanthosis Nigricans. Very simple, very straightforward. Now, the confusion is the word insulin resistance. Yes, in an obese patient, there is insulin resistance, which leads to Acanthosis nigricans, but that is not the diagnosis. That is the pathology. That is the reason why you are having it, but that is not the diagnosis. So the answer here is Acanthosis nigricans. Now, coming to Heron syndrome. Heron stands for HA is hyperandrogenism, IR is insulin resistance, and AN is Acanthosis nigricans. So yes, this patient is obese. IR is there, AN is there, but we have no mention of the hyperandrogenic features. So this cannot be the answer here. Now, fourthly, we have Cushing syndrome. Cushing syndrome may have other features as well, none of which is mentioned here. So again, that is not the answer. The correct answer to question 7 is A, that is Acanthosis nigricans, a question asked last year in the Neet PG 22. Now, Acanthosis nigricans typically presents as this velvety hyperpigmentation in the folds like the neck, the axilla, the groin, the cubital fossa, the popliteal fossa. So these are the common areas where you see this Acanthosis nigricans. Why does it happen? It happens because of insulin resistance seen in patients with various causes, because of which there may be hyperinsulinemia, which increases insulin-like growth factor 1 levels, which cause keratinocyte hyperproliferation, ultimately leading to Acanthosis nigricans. This is why in the histopath, the feature that you commonly see is hyperkeratosis. There is increased stratum corneum. There is increase in thickness of the epidermis, but there is no Acanthosis, no nigricans. Means there is no increase in thickness of stratum spinosum. There is no increase in melanocytes. That is not there. So this name on its own is a misnomer. The thing that is happening here is just increase in keratinocyte proliferation. There is no increase in pigmentation. That is a very important point that you have to remember. Now, coming to the causes, the most important associations are with the ones which have insulin resistance, like diabetes, obesity, and metabolic syndrome. Other than that, some drugs like nicotinic acid and OCPs can also cause acanthosis. And thirdly, very important question on its own is a malignancy with which it is associated, that is gastric adenocarcinoma. If a patient has a sudden appearance of Acanthosis nigricans, which increases rapidly over a short period of time, you have to think of its paraneoplastic association, that is gastric adenocarcinoma. And in other patients, it may also have small skin outpouchings, which are called as skin tags, also called as acrocordons. They are often associated with AN, and the physiology is the same, that is increase IGF-1. Now, coming to the 8th question, a 60-year-old patient presented with lesions on the face as shown below. What is the diagnosis? So what is it that we get from the question? It's an old patient, 60-year-old, lesion is on the face. Now coming to the image. So this is an ulcer here, present just below the medial canthus, and what you see is that this ulcer has a typical rolling or rolled up borders. So this is a very typical appearance that you see in the image. Then in the center you see a small ulcer. Now coming to the options, BCC, SCC, melanoma, Bowen's disease. Now where do you see rolled up borders? Where do you see the lesion as most commonly present below the medial canthus? Where? You see that in BCC. So again, a simple question here. Basal cell carcinoma, most common site, most common morphology of the rolled up borders, everything is given together in the question. Melanoma would be a black lesion. Bowen's disease would be a red, glistening or a shiny, well-defined plaque. SCC could be any physiology, but mostly it would be an ulcer, but without the rolled up borders. So other options ruled out. Classic case, classic image. The answer is BC. So now coming to BCC, as you know, BCC is the most common skin malignancy. So it is the most common skin tumor without any pre-malignant lesion. So SCC has pre-malignant conditions, malignant melanoma has, but BCC does not. And this is a malignancy where UV rays form a very important role in the causation. And where does on the body the UV rays fall the most? On the face. So on the face, if you draw a line between the angle of the mouth and the tragus, most of the BCCs on the face are above this line. And here the most common location is just below the medial canthus. This is the most common site for BCC, and this was the image that was given in your exam. And mostly the patient is going to be an elderly patient in the exam. So it will be somebody who's 60, 70 years old. In the NEET exam last year, they gave a 70-year-old patient. So mostly it will be an elderly with a chronic, slow-growing malignancy present for many years. Why is it able to be there for many years? Because it is not metastasizing. It is just a locally aggressive malignancy. It may spread in this area. It may eat up the tissue in this area, but it will not metastasize. The risk of metastasis less than 1%. When it happens to the lymphatic route. Now, these are the classic images that have been asked in your exam. When you look at BCC, it will be a pearly, shiny, skin-colored lesion with the classic rolled up borders like you eat a croissant. So it will have that kind of borders, a rolled up border, telangiectasias on the surface, a small ulceration in the center which may bleed when you scratch it. And this is how a typical BCC looks like. Then this was the image given in the November 19 exam of the AIMS. Here what you see is a dark lesion. Features are similar. There are rolled up borders, there may be telangiectasias that may bleed on scratching, but this is dark in color. So this is a variant which is called as pigmented BCC. And then there is another variant which is the ulcerative BCC, also called as rodent ulcer. Why rodent ulcer? Rodents are rats. Rat burrows. From the top you see a small hole, but on the ground there will be multiple tunnels. What does this mean? It means that this BCC here will have rolled up borders, but the margins will be edges will be undermined. So this is a BCC that typically has undermined edges. Though you see these beautiful rolled up margins, but the edges are undermined. This is the ulcerative BCC, which is called as rodent ulcer. On treatment, topically we can use 5-FU and imiquimod. Surgically, most micrographic surgery is a beautiful way to deal with it without causing much tissue damage. Then for patients who have multiple BCCs, especially the ones suffering from Gordon syndrome, there is a new drug which is called as vismodegib or sonidegib. This is a hedgehog pathway inhibitor, very useful in patients with multiple BCCs. Now, coming to the last question here, apocrine glands are seen in palm, sole, axilla, face, scalp. Tell me, what is the answer here? The answer is A for apocrine, A for axilla. Palm soles, you have most number of eccrine sweat glands here. So in palms and soles, we have maximum amount of eccrine sweat glands. But the apocrine sweat glands are present in the axillae. Face and scalp has maximum amount of sebaceous glands. Okay, so now how do you remember this? You remember A for apocrine, A for ANG, that is the axilla, nipple areola, and the groin, where you have maximum amount of apocrine glands. And another A that you have to remember with it is A for androgenic stimulation. So these glands need androgens to become active. That is why they become active at puberty. On the other hand, the eccrine sweat glands are present almost over the entire body, and they are present since birth, active since birth, have an important role of thermoregulation by sweating. So these are the eccrine sweat glands, and these are the apocrine sweat glands. Thirdly, we have the sebaceous glands, which are the oil producing glands. They also become active at puberty, and their maximum concentration is on the face and the scalp. Now, This is about the eccrine and the apocrine glands. With this, we finish our discussion on the INICET recall. Some of the question wordings, the phrases, the options may be a little different from what you have in the exam, but this is just a memory-based recall from you all, from the students. So in case you notice any changes in the options or the questions, do point those in the comment section. I hope this discussion helps you. Equally important for people who are about to give other exams as well. So all the best. Keep working hard. Success is just around the corner. Thank you.